Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Ryan. How are you doing today?
Good to see you, my friend.
Very good to see you. So today's topic is antimicrobial resistance. And I got to be honest, as soon as I thought resistance, I was like, I got to talk to Ryan. So,
well, if it weren't for antimicrobial resistance, you could make a case that I wouldn't have a job, right? So, yeah. So, this has a long history, right? So penicillin came into widespread clinical use around 1948. Resistance to penicillin came into existence in 1949, right? The bacteria, they replicate quickly, they evolve quickly, they evolve under pressure, and antibiotics are a form of evolutionary pressure on bacteria. And so we wind up selecting for resistance, and that has become an increasing challenge over time. When we think about, our therapeutic options, I will say they have improved over time. We're always in a little bit of an arms race with the organisms. But when I think about the way that I treat multi-drug resistant infections today, and I compare that to, 20 years ago when I was an infectious disease fellow back in San Diego, it has improved. It has gotten easier to treat a lot of things. But that being said, the number of these highly resistant infections has always gone up. So, it's a bit of a back and forth. But that being said, when we think about it in the military context, there's a very long history of this, and we can kind of start in the wars of Iraq and Afghanistan. And one of the stories we tell is Kyle Peterson, who is a retired Navy ID doctor who is still on faculty at USNS. Kyle was the ID doctor on the Comfort, and there's a thing called there's a listserv called ProMed that a lot of ID doctors use to kind of, it kind of gives updates on like outbreaks and, epidemics and things like that. And Kyle was seeing a ton of highly resistant Acinetobacter infections and people being medevaced to the USNS Comfort. And he kind of sends a thing like, hey, has anyone seen this before? It was unusual, it was unexpected. And so, this Acinetobacter is a gram-negative rod, and it is one of the things that I kind of say, like, Acinetobacter basically paid my mortgage when I was a fellow, because we had this huge number of highly resistant Acinetobacter infections back in the day. And this is still a problem. And I see these in our burn unit. I see these in trauma patients here in North Carolina nowadays. But at the time, it was kind of unique. And the thought was, is this something in the soil? Is this something is this something just kind of out there in the ether in Afghanistan, or in Iraq in this case, but in Afghanistan as well? Well, what turned out was when people actually started sequencing these strains, what we found is that they were, in fact, clonal, meaning they all came from a common source, meaning they came from us.
Damn.
That people were getting contaminated in the evac chain. And so there was a lot of effort placed on infection prevention and infection control in deployed medical units. And I think we made a fair bit of progress, actually. The rates did get better over time. But so there's a big study that was conducted, led by the at USNS at the Infectious Diseases Clinical Research Program under David Tribble and a number of other folks who are still working. And so this study called TDOS, the Trauma Infectious Disease Outcome Study, TDOS ran for a number of years. And what they found was, probably about at the point of injury, or at least not the point of injury, but at the first contact with the medical system in combat trauma in OIF and OEF, that probably about, somewhere around between 10 to 15% of folks were colonized with multi-drug resistant infections, mainly gram-negative rods. So that's going to be kind of your gut organisms like E. coli and Klebsiella. That's going to be some environmental organisms, things that are like water and soil, and that's stuff like Pseudomonas, Acinetobacter, and some others. And
did they ever find out where it was coming from?
Oh, just different points in the evac chain. Came from us, came from doctors and nurses in hospitals.
Sure. Like not washing hands or dirty instruments or all the above?
I think probably all of the above is a short version, but the long version is, it's a little hard to maintain sterile control if you're operating on someone in a tent. I mean, there's no, it's one of those things where I'd say it's no one's fault, but it's our collective responsibility. Like as a recovering or not recovering, but once and again division chief at my hospital, I will often tell people that, well, that problem we're dealing with, it's not my fault, but it is my responsibility. And so let's deal with it. Anyways, so, and then of folks who actually got infections, because that's just colonization, right? But the ones who were actually infected, about a quarter of them did in fact have these multi-drug resistant infections. And what do we mean by multi-drug resistant? We mean that they are resistant to most of to multiple classes of antibiotics. And specifically, the more, shall we say, broader spectrum advanced generation drugs. So like ceftriaxone, for example, ceftriaxone should be pretty active against the majority of like E. coli and Klebsiella out there, right? Those strains that are resistant to ceftriaxone, we would call those, majority of those are in a group called ESBLs, or extended spectrum beta-lactamase producers. The basis of their resistance is because they make this enzyme that can basically shred every beta-lactam antibiotic, with the exception of the carbapenems, like meropenem and ertapenem. And then and carbapenems are kind of traditionally our last line, right? Like that is what we have left when you've accumulated a lot of antimicrobial resistance. Same problem with Acinetobacter, probably about, 30-40% of people were infected with that when they had infections. And those, again, had the same problem. They were often, in fact, resistant to carbapenems. And we would often have to treat them with a class of antibiotics called polymyxins, colistin and polymyxin B being the two. And polymyxins are, mechanistically are basically intravenous detergent, right? It was an old drug then that we kind of had to resurrect out of necessity. Now we have newer drugs that have taken the place of those. So I actually haven't given either of those drugs for a number of years now because we have better, less toxic agents. But I mean, there were days when the colistin flowed like water around Balboa, around Walter Reed, around San Antonio, and around all of the larger medicines that were managing a lot of combat casualties. So this has kind of died down a little bit. And these multi-drug resistant gram-negative rods kind of get lumped together as an acronym for everything, right? So they get called the ESKAPE pathogens. It's ESKAPE with a K, so ESKAPE. And so that it's going to be E. coli, Enterobacter, Pseudomonas, which is actually spelled with a P, Acinetobacter, Klebsiella, and there's some others in the Serratia in the group. And these are all kind of endemic in combat trauma. And to an extent that we see them more than I see them in like civilian trauma patients, right? Like they clearly happen in civilian trauma patients, but there is something about the combat environment, about the medevac chain, about the kind of exposures there as compared with someone who's in a car crash or, gets shot during criminal activity in a city than happening in a desert or a jungle or what have you. And then Ukraine, the Ukrainians have been dealing, like we thought our problems were tricky, and the Ukrainians have had it even tougher, right? I mean, it's probably broadly true. You could tack that sentence onto just about anything. But, their rates of multi-drug resistance, like they have carbapenem resistance rates of like 75% among multiple species, among Acinetobacter, among Klebsiella, among Pseudomonas. Tons of different highly resistance conferring genes present in these strains. There's things called metallo-beta-lactamases that are, that will degrade almost every type of beta-lactam antibiotic. KPC genes, which we have some of here, but just they create enormous difficulty in managing these infections. Now, again, we do have therapies for these nowadays. There are some newer drugs out there. Ceftriaxone is one that we use with some frequency. There's some new agents for multi-drug resistant Acinetobacter, and these are helpful, right? And they actually have made a real difference. I actually just completed a gentleman under my care with a carbapenem resistant infection of his spine, and we are coming through the completion of therapy, and he's doing very well. And I'm optimistic that he'll continue to do well. So it's not that we can't do these things, but it's very, very difficult. And the biggest problem, I think, in the deployed environment is that how are you going to know, right? How are you going to know? Unless microbiology labs have gotten a lot smaller lately.
I have a magnifying glass.
Yeah, exactly. I can take some pretty tiny pictures with my phone if I focus carefully, right? We don't have easy mechanisms for diagnosing these, and certainly in a prolonged field care environment, you don't have a way. We can recognize the syndromes, right? We can recognize the syndromes of infection. We can recognize the syndromes of sepsis. We can offer reasonable empiric therapy, but the truth is that if I were participating in the care of a Ukrainian soldier with a wound infection, for example, in a field environment, I wouldn't know what to give this man or this woman, right? I wouldn't. And I wouldn't have a way to know until I got back to some sort of hospital. And so that raises a question of what do we do? The prolonged field, the TCCC guidelines until relatively recently, and the prolonged field care recommendations, pushed for the use of ertapenem in the field a lot. Now there's been some shifts in that guidance, and a lot of very smart folks, including a couple people that I had the privilege of helping train, worked on those. And my name is somewhere on them still, because I just can't break away from you guys yet. But we've shifted a little. The newer versions have shifted a bit away from ertapenem, and part of the problem is this constant balance in treating infections, right? Where we have both a patient in front of us, and then we have the, for lack of a better term, ecological considerations, right? Antibiotics are unique in that, like, if I'm treating someone for, let's say, anaphylaxis, right? My ability to give that person ertapenem, setting aside supply issues, does not affect my ability to give the next person ertapenem. Or not ertapenem, I'm sorry, I don't know what I'm saying, epinephrine. My ability to give someone epinephrine for anaphylaxis does not affect the effectiveness of epinephrine for the next patient, right? That is fixed. Whereas if I give everyone ertapenem, a broad spectrum antibacterial drug, that may affect and limit my ability to give it in the future, right? And so how do you balance that? Well, obviously our primary duty is to the patient in front of us, but we do have to be cognizant of that, of indiscriminate antibiotic use. And so what are approaches we can take? Well, so the guidelines for first line post-traumatic, in a Role 2, Role 3 environment for penetrating trauma is cefazolin or Ancef, a very old, relatively narrow spectrum agent that targets staph, strep, and a handful of gram-negatives, right? And the reason for that is that we tried using broader spectrum stuff. And the TDOS study analyzed a lot of this. They said, well, what happens if we give people ertapenem or meropenem at the point of injury, assuming that you have reasonably, acceptably rapid transport to a proper hospital, or at least something approximating a proper hospital, an operating room at the very least. And it turned out that we just bred more resistance down the road, and patients didn't do better. Right. And more to the point, patients didn't do better. That combat casualties, that what they really need to prevent infection is early washout, early debridement, early surgical care. A couple doses of Ancef will probably help. And that did more good than just sort of flogging people with broad spectrum antibiotics. And that's where those guidelines came from. And that is evidence driven. In the pure field environment, where, Ancef is a drug you give every 8 hours. It's not the most field stable thing in the world. There are longer acting drugs that are a bit broader spectrum, but may be an acceptable balance. We talk about ceftriaxone a lot in this setting. That may be kind of the optimum balance for it. It will not treat an MDR infection, but the best thing we can do to prevent those is going to be good wound care, careful washout, careful use of the sterilist technique that one can use safely. And when evacuated, early surgical intervention, right? And that's what, the best antibiotic for a lot of these things is a knife. Yeah.
And I guess I wanted to ask, but it felt kind of stupid to ask, but
Never
just
stupid.
basic soap and water.
Yeah.
Most of our tubes, most of our IVs, though we are supposed to use alcohol, you're supposed to use betadine, etc. Let's be honest, like it can be hit and miss because like I got some stuff I need to do right now.
Yeah. Right.
And I've been wondering, like, just good soap and water, even after the fact, cleaning once things have settled, be able to try and clean the patient, clean out the wound, just soap and water. Like, does that do much of anything?
I think it is better than nothing, right? I mean, probably the purest answer would be something like chlorhexidine, which is relatively field stable and is pretty easy to transport and is certainly going to be a little less messy than betadine. Betadine requires some contact time too. So does chlorhexidine, but it's not as long. You don't have to sit there for 5 minutes waiting for it to dry like iodine-based solutions, whereas chlorhexidine, you get an acceptable amount of contact time on it, then you can get to work, right? Like when I'm doing an emergency procedure in the ICU, and I don't have the opportunity to be quite as sterile as I want, I put on sterile gloves, I splash a bunch of chlorhexidine on it, give it a minute to dry while I'm getting my gear together, and then you go, right? And is that as good as a proper full sterile technique? No. But sometimes we can't, sometimes beggars can't be choosers, right? Is soap and water better than nothing? 100%. 100% it's better than nothing. You do worry about kind of the causticity of some things and the impact that has on an open wound. I think things kind of but I think kind of the pure, non-scented soap things are better. It is clearly better than nothing.
Okay.
Right?
Can you really knock that bacterial load down very much with just cleaning it out?
You can knock it down some. I mean, there is a reason that surgical antisepsis doesn't use soap and water. It was, in kind of the Joseph Lister discovered surgical antisepsis back in, was it late 1700s, early 1800s? I mean, he was using carbolic acid, which is probably overkill for us nowadays. But I would say if you've got access to chlorhexidine or can just jam some Chloropreps in your pack, they're small, they're light. That would be my first choice. Betadine swabs would be an acceptable second choice. If soap and water is what you got, well, again, beggars can't be choosers. But I think the other two are going to be a little faster. It's going to be a little cleaner. It doesn't require an external water supply, which is nice, because obviously for soap and water, you need both soap and water. Yeah. Neither of which are necessarily as reliable as we'd like. Yeah.
Now, after the fact, after the chest tube is, like, let's be honest, it's dirty, or the Crike is dirty, the IV, etc. Yeah. Going back after the fact, either potentially replacing those things, cleaning those wounds around.
Cleaning the wounds around is certainly very reasonable. And, we, like in the hospital, we have, chlorhexidine impregnated dressings we put on these things. Not on Crikes, but on chest tubes and lines and things like that. So if you can at least clean off the outside, that is a start, right? That is a start. Generally, what I would say is probably, depending on evac time, standard warnings, etc. I would say that I would leave those most of the time unless your patient was in shock due to infection, and let those be fixed, not fixed because, it was a successful procedure. Let it be made pretty when they get to someplace a little more stable. Yeah.
Let's say, we've done our best. Yeah. We've actually been able to hold on to a patient successfully. We've been giving antibiotics, whether it be Q8 hours or Q24 hours, exactly as the guidance has been written.
Right.
Finding out if an antibiotic works or not is not a rapid thing.
It is not. There's kind of an old, sort of ID doctor observation that with an invasive bacterial infection, we'd like to see fever clearly improving, if not gone, within 72 hours. Right? So, if a patient is persistently febrile, not clinically improving, and it's been 72 hours, then that is a strong marker of failure. And that can be from resistance. It can be from a lack of source control. It could be from, deep-seated abscess, perforation, things that may not necessarily be that difficult to sort out what it is. Whether you can do anything about it is another question, of course. But 72 hours is sort of the rule of thumb. Like, I don't expect people to be perfect by the next day. But, I would say this, even if you're maybe not, infections develop over the course of hours to days, not over the course of minutes, right? And that agent you're giving, be it cefazolin, be it ceftriaxone, be it ertapenem, for that matter, obviously, if you're still managing this person in a week, then something has gone horribly awry, right? But if you're managing this person over 48 to 72 hours, and you've given a comparatively narrow spectrum drug, right? Yeah, maybe you haven't treated the Acinetobacter infection that is still probably in the process of setting up shop, right? Because that's going to take time. These are going to be relatively low inocula, and they're going to take time to reproduce. They're going to take time to establish infection, right? But what you are doing is you're preventing that staph infection, that streptococcal infection. And like those things, Acinetobacter and Pseudomonas are opportunistic pathogens. They are not that virulent. They require, like, if you or I walk into my ED or the ED down at Womack or whatever with pneumonia or cellulitis or something, like, I'll tell you what you don't have. You don't have Pseudomonas, right? You don't have, because it's an opportunistic pathogen. It requires some violation of your immune system to get it. And that violation can be a mechanical violation, like a big hole in your leg or in your chest or something, or a tube down your throat or something like that. It requires, something's got to be wrong with you, right? These are not community-acquired infections, and they take time. Whereas Staph aureus or like Group A strep or Group B strep, that stuff will kill you, right? Those are high virulence pathogens that cause invasive disease in potentially very healthy people, right? And I have, cared for, both on active duty and not on active duty, on plenty of highly invasive staph and strep infections that have, very nearly, or in some cases successfully, taken the life of a young active person of military age. And so even if our empiric management in the field does not necessarily address MDRs, you're still doing something about that other stuff. And, familiarity breeds contempt and everything, right? Like staph and strep, you're like, oh, that's everywhere. Who cares, right? Group A strep in your blood, that'll kill you. That'll kill you, right? There is a reason that we take that stuff seriously. And so that I say that to say that those efforts that we make, I keep saying we because obviously I'm retired and I have a beard now, and and I'm balding and all that stuff. But there's a reason that we have therapy that targets those things. Because if you look at, the infections of the olden days, they were either things that essentially require surgical intervention, like gas gangrene, Clostridia, things like that, or they were staph and strep, which are rapid, fast-moving, highly virulent, and lethal if untreated. So that's why our efforts, even though we may not be getting, even though we don't have, ceftriaxone and, meropenem vaborbactam in the field, we're still doing, from a public health standpoint, if we consider combat casualty care a form of public health, which I do. From a public health standpoint, we are doing significantly more good than harm with that approach, right? So I think that's okay. But yeah, prevention ultimately is the best thing we can do. And part of prevention is, selective, is using these newer drugs selectively, which is not really a thing that one can deal with in the field. But the other part of it is, like you're saying, good wound care, good hygiene, all of those sorts of things. That's going to make a big difference down the road, right? And good resuscitation, right? Like, the well resuscitated patient with good hemostasis is less likely to develop a devitalized zone that is going to subsequently become bacteria food, right? And so all of those things make a big difference.
So thinking about like antibiotic, like timing, and I don't mean like every 8 hours or 24 hours. I mean, how soon
Time to
should
therapy?
we be? Yeah, because we were super rapid. We need blood. We need TXA. We need calcium. We need narcotics. I have yet to hear anybody panic about we need antibiotics on board.
Yeah. Well, I mean, I panic about that with some frequency, actually, but that's more of a function of what I do. So it depends on how sick you are, right?
But it just happened.
Yeah.
T-tri-C.
Yeah. So it just happened. You just took, I would say it would be nice to get that in within the next, so the prophylactic antibiotics, ideally within an hour, right? Ideally within an hour. You could extend that out to 3 hours, but I think that would be under extraordinary circumstances. Ideally within the hour would be good practice. And that's sort of a indirect extrapolation from the timing of, perioperative prophylaxis. We like to give antibiotics within about a half hour or so of the first incision, right? And so we'll kind of work backwards from that and say, well, if you get it in within an hour, that's probably better than nothing. But sooner is better. When it comes to the patient you think is infected, right? Then it becomes a question of physiology. The patient in shock, and you think that shock, there's a reasonable chance that shock is the result of that infection, then you have an hour. And the reason for that is that the time of hypotension until the time that active antibiotics are on board is the one, other than source control, is the one modifiable risk factor for outcomes in sepsis, right? That only applies to the patient in shock. In the septic patient who is not in shock, you have up to 3 hours, depending on, your degree of suspicion and, other evaluations. Do you have a compelling alternate diagnosis? And, so that's basically it. 1 hour if they're in shock, 3 hours if they're not.
Routes, obviously, IV would be ideal.
IV is ideal. And that would say, if you're looking at things like the Surviving Sepsis Guidelines, IV is basically what it says. There isn't a lot of data about intramuscular antibiotics in this setting. It's probably fine. You can give ceftriaxone intramuscularly in a properly resuscitated patient. If someone's got a dirty epi-drip, it's got kind of a jury-rigged epi-drip running, I'm not sure what the perfusion of their muscles is, and that could affect uptake. So I would say the patient in shock, well, you got a line into them, so give it through the line. The hemodynamically stable patient, I think you could make a case for oral.
Because what I'm thinking of is a lot of times while we're working, maybe we'll get 1 or 2 lines in. One is almost dedicated for resuscitation. The other is hopefully for
other things,
other stuff, right?
Pain, analgesia, things like that.
And, some guys will be like, well, I'm doing this other thing with this other line. I don't want to stop that to give antibiotics.
Well, I would say here is an advantage to most beta-lactam antibiotics, right? And we'll take ceftriaxone and cefazolin as the two kind of prototypes here. Those can be given by push dose. Squirt it in. You're done. It takes a minute, right? You can do it by slower pushes, but these are things that can be given rapidly and quickly, right? If we're talking like vancomycin, right? Vancomycin is an hour infusion time. Well, that's not practical. And honestly, I'm not sure there's any way to really give vanc in the field, to be honest with you. But
ceftriaxone, I can just push it.
Cefazolin, you can just push it. Yeah, load it into syringe and give it. Same thing for both of these. These are quick administrations. They're in, you're done, you move on to the next thing. And if you need to briefly interrupt, whatever it is you're using, that second line, that's really one of the big advantages to ceftriaxone and to cefazolin, and really most beta-lactams, certainly most cephalosporins. A little trickier with penicillins, but that's not really an issue for you in the field. This is actually a thing that we talk about a lot as sort of a sepsis quality metric, right? So in hospitals, time to antibiotics is one of these measurable things that we try to improve in the genuinely septic patient. And there's some very simple strategies that improve outcomes, and one of them is just having a bunch of push dose ceftriaxone, cefepime, et cetera, locked and loaded in the emergency department or in the ICU, so you can just go pull it out of the Omnicell or whatever pharmacy storage device your hospital or unit has, walk over, give it, now move on. And then that leads to measurable improvements in outcomes. And although that isn't studied in the field setting, I would be shocked if it didn't have similar benefit, at least for the seriously ill person.
So we had mentioned earlier, hey, 48 hours, 72 hours, things they don't seem like they're getting better.
Yeah.
And I mean, for some reason, the patient doesn't realize that I gave them antibiotics, so it's supposed to get better.
And you're not. Yeah.
What do I have these, right?
Yeah.
So,
so it kind of depends.
Do I just start throwing things?
Well, and I think that becomes unknowable, right? And I don't know if I have a straight answer for that one. I think what I would consider in that setting is trying to see, is there anything from a source control standpoint that one can do? Because that is a thing that we could do. Obviously, if it's penetrating intra-abdominal trauma or something as a source control issue, well, that's going to give you other issues, although then considering bleeding is another issue. I'd say this. One is that fever doesn't kill people, right? So the person has a pulse, has a pressure, is talking to you, is reasonably well perfused. You look at their capillary refill and all that. They're still febrile, but they're awake, or at least they're awake, they're able to talk to you, and they have a blood pressure. That situation is not desirable, but that person is not about to die, right? I would certainly look for source control issues. So is there an infected wound? Is there something I can open up? Is there something I can debride? Is there something I can drain? The devices I put into them, the chest tube, maybe I do need to change that. If that's starting to show some signs of purulence, if if you've got something coming out of the tube that looks a little unhealthy, maybe we do need to swap that, or at least try to do some sort of debridement or debulking of that infection if possible. Your choices for antibiotics in the field are going to be relatively narrow, right? When I think of things that one could consider, and this would be very context specific, I'd say one thing is if you have access to telemedicine, give us a call. Right?
Sure. Of course, the advisor line.
Yeah, use the advisor line. But other things that one could consider, there is an oral antibiotic. It's also available IV, but linezolid, which used to be relatively expensive, but it's pretty inexpensive nowadays, and that is a very broad spectrum gram-positive drug. It won't help you with the gram-negative stuff, but it is a very good agent for resistant staph and MRSA. And that's actually a pretty good choice. And that would be a thing to consider if you had that on hand. We had talked about it back when I was active duty about, for like soft tissue infections, should we have this available in the field setting? And I got to be honest with you, I'm not sure where that went, but that would be an option. And very much is a future thing. Like, this is not particular, to the best of my knowledge, not particularly close, but there are a number of oral drugs nowadays that are pretty broad spectrum and pretty safe. They also, I think I figured out that some of these are probably, the cost of them is probably best measured in like how many fully loaded laptops could you buy with a full course of them. So, but they have, some of these manufacturers have been working with the military, looking at would these have a role in a field setting, and so eravacycline, omadacycline. Some of these other ones that would actually address a number of these Acinetobacters and these highly resistant clubs. They wouldn't get Pseudomonas, but they'd get most of the others. I remain curious about that. There's actually some interest in them from a biodefense standpoint, because some of these would also treat a number of potential biowarfare agents like plague, tularemia, probably not anthrax, but plague and tularemia for sure. And so there is looking at military applications of these newer drugs for self-protection and potentially for combat casualty care. So that's a little pie in the sky right now. I think we're probably not quite at that point. But that would be interesting to see if those became agents that would become useful, in a deployed setting, because they're, people basically aren't allergic to them. They're very bioavailable. You can swallow. They're reasonably broad spectrum. Again, just exploratory right now, but kind of cool. Yeah.
So at this last SOMSA I was talking to one of the Ukrainian medics, and he was just telling me like a case. So it's a case from a guy.
Yeah.
And he was telling me about this patient who had been out there for a week or so, definitely infected.
Yeah.
He seemed to be resistant to whatever it was they had given him.
Yeah.
Right. And I was kind of expecting something really advanced to happen. Yep. But he said we gave him doxycycline and he got better.
Yeah, well, so a metacycline is a tetracycline derivative, like doxycycline.
Okay. So it seems like the new stuff. Yeah. Things get resistant, and then you go retro, and it crushes it.
Sometimes, yeah. Well, minocycline is another old drug, just as old as doxycycline, that we actually did and still do use a lot. And if I were stuck, there's an old ID doctor expression that no one dies without doxycycline. But doxy or minnow, give it a shot, man. We're in North Carolina, right? That's, Rocky Mountain spotted fever out here. Those are that is the drug of choice for that. So, yeah, no one dies without doxy. I salute this gentleman.
Maybe it was like, we have this, give it a shot, kind of situation. Yeah. But I'm just wondering if these bacteria advance so fast that
do you sometimes regain susceptibility? Well, I would say tetracycline resistance in a lot of these things is just not that common, right? And they haven't had a lot of evolutionary pressure from them. But doxy, and I would say even more so minocycline is a good drug, and it has a lot of interesting properties, and it is probably underutilized in the setting. But we certainly gave people a lot of minocycline back in the day, because it did treat a number of multi-drug resistant Acinetobacters. And actually a gentleman who I took care of for, since I was a fellow until I retired, I would leave San Diego and I'd come back and pick him up again. And now I had him on minocycline and amoxicillin for a highly resistant Acinetobacter infection. Took both of his legs. He walked around on some great prostheses, became a competitive distance biker with his prosthetic legs. Super cool guy, wrote a book. I had him on minocycline and amoxicillin basically forever. Did fine, lived his life, got married, had kids, just extraordinary guy. But yeah, minocycline, great drug. Yeah.
When it comes to just antimicrobial resistance, any other tidbits that us in the pre-hospital should not screw up?
Yeah, wash your hands. Honestly, that's the beginning and the end. We are all vectors, my friend. Wash your hands. That's the biggest thing. We do our part in the pre-hospital setting to at least, I can't control the supersonic dirt that got blasted into your leg, but I can control what I put on you, right? So good, careful hand hygiene and good wound care. If we do that, that's going to solve, 80% of it. The rest of it we'll figure out later.
Awesome. Well, thank you, Ryan.
It's always a pleasure, my friend. It's great to see you.
Hey, great seeing you. Thank you again.
Take care.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.